Thank you, everyone, for joining us for today's session. Am I audible, Sri Priya?
Yes, ma'am.
Sorry for the background noise. So, as we have discussed during the last session, today we'll be discussing about the step 3 analgesics. So, we'll be focusing mostly on opioids, especially in an Indian context. I know that there were a lot of questions regarding the morphine and the conversion. I am sure that everything will be covered in today's session. Today we have Dr. Sunil Kumar. Dr. Sunil is the additional director of Trivandrum Institute of Palliative Sciences. And he is with palliative care for around 20 years now. And he's been involved from the beginning when palliative care started in Trivandrum. And he has immense experience in dealing with most of the opioids, including the recent one, methadone. He has done his post-graduation in palliative medicine from Cardiff University, UK, and he's also honorary tutor of Cardiff University. Welcome you, sir, for today's session. Over to you.
Thank you, Sridevi, and good evening, everybody. So you have already covered the first and second step of WHO analgesic ladder. So we'll be focusing on third step, especially on the opioids for moderate to severe pain. And you know that there are 3 opioids available in India in the third step: morphine, fentanyl, and methadone. But we are trying to cover methadone and fentanyl in this session, and there is another session on methadone. So we'll be focusing on morphine, fentanyl, and mechanism of action, and practical aspects. Even though many of us use opioids, we sometimes will have many doubts what to do in certain situations and things like that. So we will try to cover that. Then what are the adverse effects of opioids? This is one of the most important area when we cover opioid. And it is also important to understand the price of different opioids, because many a times what happens is that we prescribe some medicines for the patient, and in the next review, patient will come and tell you that I don't have any symptom relief. And then we will try to increase the medication or change the medication. But what happens is that most of the time these patients are very poor to afford medications, and medications like fentanyl patch or gabapentin or pregabalin, which are costly, so they will not simply buy it. So it is important for us to understand what is the comparative price of different opioids. So you know this WHO analgesic ladder. So I am starting with a story of a patient. This patient, when you see this photograph, what is that stuck your mind? Anybody? Or what do you understand? Is there anything that is of concern for you from this photograph?
Patient is sick.
Patient is
malnourished. Patient is sick. Patient is cachexic.
okay.
He is complaining of some kind of pain surrounding his mouth and hands.
Yes. Yeah, you are correct. Anybody else? What is your primary concern when you see this patient?
He's completely tired.
Yes. Yes.
There are few more chats where patient is saying remaining.
Yeah. So there are many things which you can make out from this photograph. But the first thing which you should be concerned in this patient should be his facial expression, isn't it? His facial expression says he's in some distress. He's in severe pain. So this is a 56-year-old man with carcinoma of the larynx, and he has the most important problem for him is pain. It's a continuous pain around neck, and he scores 10/10. And he was unable to sleep because of pain. So you can think of a person, or you think about yourself, whether you will be able to manage this pain for 2 weeks if it happens to you. Most of us might have experienced some type of pain, mostly maybe toothache, and one day because of this pain you were unable to sleep. But here there is a person who was unable to sleep for the last 2 weeks due to severe pain. So if you see a patient like this, or if he comes to your hospital, how will you manage this patient? Anybody can unmute and speak.
Yes. So, hello.
Yes. Yes.
So, the first thing you might want to do is to actually assess the pain score of the patient and see whether it is mild, moderate, or severe. So, depending on the severity of the pain, that can give you an idea of what to do or how you can treat. And then you can actually assess the character of the pain. So that could actually tell you whether it's a kind of neuropathic pain or a kind of nociceptive pain, which could also affect the way you manage the patient.
Okay, thank you. Can you identify yourself? Your name, please.
I think you're muted, Dr. Chakra.
I am Dr. Gregory Fourier.
From?
I'm from Sierra Leone. I'm currently in KIMS.
In KIMS?
Krishna.
Okay, I didn't get you properly, sorry. But anyway.
Yeah, I am from, okay.
Yeah, please.
Yeah, so I said I'm from West Africa.
Okay.
A small country. Yeah, I'm from West Africa.
Okay, thank you. So what you have told is right. We have to assess the patient for pain score, but here the patient says it is 10/10. So the patient has very severe pain, and he says it is a continuous type of pain, and the quality is sharp pain. So all around the neck, no radiation. So how will you manage?
Yeah, so we can, hello again.
Yes.
Hello.
Yes.
Yeah, so because of he's already described the pain, and that is a severe pain score 10/10. So we can move up to step 3 WHO pain ladder. That is, we can actually combine maybe step 1 and step 3, and then we can add some adjuvant therapy to it. That is, you can start off with morphine, you can add some non-steroidal anti-inflammatory, and then you can give anxiolytics to this patient. So the patient, because he's not sleeping, so all those ones can help the patient.
Okay, thank you. What you have told is mostly right, but regarding the use of anti-anxiety medication to sleep, here patient is unable to sleep because of pain, isn't it? So if we are able to relieve his pain, probably he should be able to sleep. So we should treat the root cause of the problem as far as possible. So in palliative care, we say if there is anything correctable, we should correct it. So here the correctable factor for insomnia is pain. So we should correct or relieve the pain or reduce the pain so that he will be able to sleep. Otherwise, I agree with what you have told. We have to move on to the step 3 WHO analgesic ladder. So through which route would you like to give morphine in this patient?
Oral routes. That is the best route I can give. Oral.
Oral. Okay. Suppose I'm asking this to all. Suppose you are in severe pain. How fast would you like to get pain relief?
As soon as possible.
As soon as possible. So what do you want here? Tablet or injection?
Injectables.
Injectable. Yeah. So even though the efficacy of both injectable and tablet are same, but the injectable preparation will give faster pain relief. So you can give injection. Anybody is experienced with how to use injectable morphine for such severe pain?
Sir, may I try?
Yes, yes, please.
Hello.
Hello.
Yes, please go on.
Sir, actually morphine we dilute and we give an aliquots of 1 milligram. We see till where the patient has control, the patient gets comfort or relief. We monitor the blood pressure, heart rate, everything. We hook the patient to monitor first. And then we give 1 milligram aliquots and we see the total amount that the patient needs for pain relief.
Yeah. Thank you, Dr. Sanjaya. Where are you from?
I'm from Delhi, sir.
Okay. Which hospital are you working?
Sorry, sir. I'm Dr. Sancha. I'm working at IBHAS. I have done palliation when I was in Bangalore in St. John's.
Okay. Okay.
Okay, sir.
Yeah. So there are various methods by which you can actually titrate injectable morphine. So you can see.
There
So
are
this
another
patient-
response also, sir. We
Uh-huh.
dilute 1 vial of 15 milligram morphine in 9 ml distilled water by Dr. Amina Majid.
Okay. Yeah. Yeah. So you can see this patient after an hour, he is smiling at us. So this is the magic of injectable morphine, or this can be achieved also by administering oral morphine, but this is faster. So what made this smile? It was by intravenous morphine trial or intravenous morphine titration. So this intravenous morphine titration, which was actually, there is a paper published by our chairman and his colleagues way back in 1996, and we follow that method. So in that method, injection morphine is given at 1.5 milligram at 10 minutes interval. So injection morphine 1.5 milligram at 10 minutes interval, because the available ambule to us is 15 milligram in 1 ml. So we will dilute 1 ml of morphine with 9 ml of normal saline. So total 10 ml contains 15 milligram, and each 1 ml of this diluent contains 1.5 milligram of morphine. So you will give injection morphine 1.5 milligram at 10 minutes interval. What is the immediate side effect you are expecting by administering injection morphine? Anybody?
Vomiting.
Yeah.
Myself, Dr. Anish.
Yes.
Hello.
Yes, Dr. Anish.
Yeah, myself, Dr. Anish. I'm working in LIMS. So actually, I was about to speak earlier, but since the patient has severe pain, I wanted to suggest maybe fentanyl IV in the beginning, so that he will get a sudden relief, and further give morphine. Or if you're going with morphine, we can give dilute and give 3 milligram first, then give 1.5 every 10 minutes. And regarding this immediate side effect, what we are expecting is that nausea, vomiting, and even respiratory depression we have to watch for. Since the patient has CL larynx, his airway may be compromised. So we must be prepared to keep a difficult airway tray ready, even in case of sudden respiratory depression, which can even lead to tracheostomy. If the patient already has tracheostomy, we can go for suctioning and all, which can help. So oxygen support should be a backup. So
Okay.
that's my suggestion.
Okay, thank you, Dr. Anish. Injection fentanyl is something which is used by specialists who are very much experienced in pain management, because even injectable morphine is not available at many places, but if available for palliative care physician, it would be injectable morphine. So we use both injection fentanyl as well as injection morphine, but worldwide morphine is the gold standard for pain relief. Injection morphine would be better, and I would advise you to go with 1.5 milligram at 10 minutes interval. And if the patient has a very severe pain, 10 by 10, it is not usually going to produce any respiratory depression. I have given thousands of intravenous morphine trials, and I haven't even come across any respiratory depression. It can occur if you give it in bolus doses, high bolus doses. Otherwise, usually it is very, very rare. So as Dr. Anish told, the immediate side effect that we are expecting is nausea and vomiting. So we should give injection metoclopramide 10 milligram IV before starting injection morphine. So injection metoclopramide 10 milligram IV followed by injection morphine 1.5 milligram at 10 minutes interval. And what is the endpoint of injection morphine titration? How long will you continue to administer morphine?
Till pain subsides.
Till
And
pain
then-
subsides? Any other endpoints?
Then maintenance dose we have to give every 4 to 6 hourly.
Yes, thank you, Dr. Vijay. Till pain subsides, or are there any more endpoints?
So we look for drowsiness or sleep. So that is overdosing. So then we take the next lower dose. That is what we give.
Yes. So either the patient should have satisfactory pain relief, or patient should be sleepy, whichever be the first. So we have to understand that morphine is not a panacea for all types of pain. And some patients with injectable morphine, the drowsiness will come first. So we have to stop the trial then. Otherwise, if you continue to give, then you will produce all the complications like respiratory depression. So if you stop it here, when the patient is sleepy, then the patient will not go into respiratory depression. Okay, so these are the endpoints. So as Dr. Sanjay told, we have to make a chart like this, which includes pulse rate, respiratory rate, blood pressure, pain score, is the patient drowsy or not, and what is the dose of injection morphine you have given. So you will administer morphine at 10 minutes interval after looking the patient, is he drowsy or not. If the patient is not drowsy, you can continue to give injection morphine. So you can see in this patient, he received 3 doses of injection morphine, and his pain score came down to 1, and the patient is not drowsy. So we have to stop the trial because the patient has good pain relief. Pain score is now 1. Okay, so this patient, he received 4.5 milligram of morphine with good pain relief, and we would like to send this patient home. So how are you going to convert to oral morphine?
You multiply by 2.
Oh, sorry, unable to hear you properly.
You multiply by 2.
Multiplied by 2.
Because the multiply, because the IV morphine is 2 times stronger than the oral morphine. So you just multiply by
Okay.
2.
Okay. Anybody else?
Hello.
Yes.
4 to 20 milligram 4 hourly.
20 milligram.
5 to 20 milligram approximately, up to within interval of 4 hours.
Okay. So As per the study which has been published, which I told you, which converted the same dose of IV morphine to oral morphine. So 4.5 milligram of IV morphine was converted to 4.5 milligram of oral morphine. 4.5 milligram tablets are not available. 10 milligram tablets are available. So we can give 5 milligram tablets. Okay. So you might have doubts regarding this, whether will it be enough. In this, the study conducted, all the patients had a very good pain relief with the same conversion ratio. And the logic behind this is that if you give injectable morphine and to reach or to have a sustained blood level concentration, it will take about 24 hours. Then after 24 hours, if the patient is on injectable morphine, then when you convert from IV to oral, maybe even you can multiply by 3. But here this patient has received morphine only for the last maybe 40 minutes. The blood level has not stabilized. So it is not wise to convert it into more doses or multiply it by 2 or 3. So the same dose can be converted to oral dose. So here we can give same dose, that is the practical doses 5 milligram. So tab morphine 10 milligram, half 4 hourly. So morphine, tablet morphine is usually given 5 times daily. Even though we says 4 hourly has to be given, you can see at bedtime that double dose is given and the 2 a.m. dose is skipped. So this is how tablet morphine is administered. And in addition, you can also give SOS dose. The regular dose can be given as SOS dose. And many of the institutions may not have injectable opioids. So in such cases, you can give tablet morphine. If the patient is opioid naive, then you can start with 5 milligram. Or if the patient is on already on weak opioids, start with 10 milligram of oral morphine. So this patient, we started him on 5 milligram morphine 4 hourly and SOS dose. He was relatively pain-free for the last 2 weeks, but then he needed 4 SOS doses per day. What shall we do now? And how frequently would you give SOS dose of oral morphine? Anybody?
So, hello.
Yes, Jigar.
Yes, so the SOS doses can be given at any time in between the 4 hourly doses that the patient is supposed. So once he has the pain, then the SOS dose can be given. And at the end of the day, you calculate all of the SOS doses together with the regular dose, and then that will give you a fair idea of what is the morphine requirements of the patient.
Yes, thank you. But what should be the difference between, or what should be the time interval between 2 doses?
No gets you, sir.
What should be the time interval between 2 doses of morphine?
4 hourly. 4 hourly. Should be 4 hourly.
Minimum 1 hour.
Okay. 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 Thank you, Amina. So this patient, you can see he had a good pain relief, but then later he needed 4 SOS doses of morphine. That means this patient now requires more morphine. That's why he is taking 4 SOS doses. So as Dr. Gregory told, we have to increase the dose of morphine. So how will what is the indication to increase the dose of morphine? So the indication is when the patient takes 2 or more than SOS dose. PRN is same as SOS dose. Okay. And in that case, you can increase the total dose of morphine by 30 to 50%. Even morphine, the dose can be increased every 24 to 36 hours. You need not wait for 2 to 3 days. Okay, so here the patient is taking 5 milligram of oral morphine, and 30% of 5 milligram, it is 1.5. So which is not practical. So the next possible is 50% of 5 milligram, which is 2.5 milligram. That is 7.5 milligram every 4 hourly. And sometimes the patients will find it very difficult to break the tablet into 4 pieces. And in such cases, even you can increase it to 10 milligram 4 hourly. So basically, what you have to understand is when the patient is taking 2 or more than SOS doses, you can increase the dose of morphine. And how frequently you can administer morphine if the patient has pain? Dr. Gigre told that 4 hourly, but suppose the patient has taken morphine at 6 a.m. and patient complains of pain by, he says at 6:30 a.m., my pain is not relieved. What would you do?
You can, because the onset of the morphine is basically like 20 minutes onset. So there are times if you just take, you expect immediate pain relief, then definitely that will not sound so okay. So you wait until the onset, you have the peak onset of the morphine.
Yes, thank you. So we will see what is the peak onset. Okay, so this is, you can see the poppy flower and poppy field. And poppy plant is legally grown in 3 states in India, UP, MP, and Rajasthan. And the seed-like thing is known as pod. And you can see the farmers are making small cuts in the pod, and the sap is coming out. So they will collect it, dry it in sunlight, and will transport into government opium and alkaloid factories, where they will make morphine powder out of it. And this morphine powder will be transported into various pharmaceuticals, from which they will make morphine tablet and injections. Okay, so morphine is a weak base, and it is absorbed from the upper small intestine. And it is hydrophilic, so it is water soluble. Because of that, it has a slower onset of action, but longer duration of action. So morphine, usually we say it acts for 4 hours. So many people administer morphine sublingually, which I think should not be done because absorption is very low, and you have to keep it under the tongue for hours. So if anybody says after sublingual administration, I have good pain relief, that means the patient has swallowed it. That's why he has good pain relief. Buccal and gingival root is also not advisable. If you powder the morphine, it has a bitter taste. So when you ask the patient to powder the morphine, ask them to sweeten it. So after absorption, what happens? When you swallow, it will go into the GI tract, and it is absorbed into the blood vessels of the intestine. And from there, it will go to the portal vein, to the liver, where metabolism takes place. So liver is the place where major metabolism of morphine takes place, and metabolites are liberated into the systemic circulation. In addition to liver, intestine and kidneys, minor metabolism takes place. And 90% of morphine is converted into metabolites. There are 2 major metabolites, morphine 3 glucuronide and morphine 6 glucuronide. So you can see morphine M3G in short, it is produced in larger quantities, 45 to 55% M3G, but M6G forms in 5 to 10%. And the M6G is the active component which will give you pain relief. M3G doesn't have much action in our body. So M6G is the active metabolite, which will give you pain relief. So morphine has to be absorbed from the small intestine, goes into the portal vein to the liver where metabolism takes place, and the metabolite M6G is liberated into the systemic circulation, which will give pain relief. So this action will start by about 30 minutes, but the peak action of oral morphine is by 1 hour. So it is better to wait for 1 hour before you administer the next dose of morphine. So the difference between 2 doses of oral morphine should be 1 hour. That is ideal. So our patient's pain was stabilized with 10 milligram of morphine now, and he is taking it away 4 hourly. But the patient says it is very difficult to take it every 4 hourly. Sometimes I forget it. Is there any way you can give it less frequently? Is there anything that you can do for this patient? Anybody?
Sustained release tablet, sustained release morphine.
Yeah. So sustained release tablets. So this patient is taking 60 milligram of oral morphine per day, isn't it? 10 milligram for hourly means it is 60 milligram. So what would be the dose of sustained release morphine?
30 milligrams BD.
Yeah.
30 milligram
Yes,
BD.
yes. Thank you, Dr. Gigre. So sustained release morphine, the duration of action is 12 hours. So you have to give it every 12 hourly. That is tab morphine SR 30 milligram BD. But sometimes this patient may have pain. So you have to give immediate release morphine also. The same dose, that is 10 milligram. So this is how you can reduce the dose of morphine, not dose of morphine. The frequency of administration can be reduced if sustained release morphine is given. But the problem is that compared to immediate release morphine, this is 3 or 4 times costly. And these are the various preparations of morphine available. Aqueous solution, that is syrup. Tablets, 2 types, tablets and capsules are also available, immediate release as well as controlled release. Then injection morphine. Morphine suppositories are not available. So our patient, he is on a 10 milligram morphine every 4 hourly, but after 6 months, he was brought to you with excessive drowsiness. And you don't know what is the cause, so you thought you will investigate, and you found out that his serum creatinine is 5 milligrams per deciliter. Is there anything that you need to do with morphine dosage now? Anybody?
You can reduce the dose of the morphine.
Okay. Why do you want to reduce the dose of morphine?
So it's as if toxicity has started setting in. So with the creatinine being raised to 5, which means the kidneys are already impaired. So there is higher likelihood that the patient will have toxicity, which is responsible for his excessive drowsiness.
Okay. So morphine and its metabolites.
No need to reduce.
Sorry.
There is no need to reduce.
To reduce, there are so many other chats also telling to reduce, decrease the dose to 50%.
Okay. So this patient has excessive drowsiness. Probably, if we have ruled out other reasons for drowsiness, it might be because the morphine and its metabolites has accumulated due to renal failure. because morphine is excreted from the body by glomerular filtration. So if the kidney is not working, what happens? Morphine and M6G and the other metabolites gets accumulated. So whatever you are giving, it is there in your system. So this will cause excessive drowsiness. So you have to actually maybe you can skip 1 or 2 doses of morphine till the patient becomes more alert and then start with a smaller dose. Maybe even the dose of morphine has to be reduced, and the frequency of administration, instead of 4 hourly, you have to make it 6 hourly or 8 hourly or TID. And even once daily, I have had a patient who was undergoing hemodialysis, and this patient, he requires only 1 dose of morphine, 5 mg, and with that he has good pain relief till the next hemodialysis. So you have to be very careful. Or you can give alternate opioids which are renally safe. So which are the other opioids which are renally safe? If you want to start the patient on some other opioids which are renally safe, which are the available ones?
There is a response, fentanyl.
Yeah.
A few people have mentioned fentanyl.
Yeah. So fentanyl is an option. And methadone is also renally safe opioid. So these are the options, but both of it has its own disadvantages, because fentanyl is not widely available, and cost is another factor. Methadone is not used by many of the palliative care physicians in India. So keep it in mind that methadone and fentanyl can be used in this situation.
Sir, there are 2 responses on tramadol. Would you like to?
Yeah.
comment on that?
Tramadol is also comparatively safer, but in end stage renal disease, the dose of tramadol should not be more than 100 mg. So it can be given, tramadol can be given, but when it comes to end stage renal disease, the dose should not be more than 100 mg per day. That's what the literature advises. So our patient, he was sent home with 5 mg of morphine 8 hourly. So he's taking only TID, and he has good pain relief. But he was unable to swallow anything, including morphine, probably because the patient is near end of life, and he's at home. But if he is not taking morphine, he has severe pain. So what will you do now for pain relief for this patient? How are you going to help this patient? Anybody?
There is like few responses on fentanyl patch, RT, subcut morphine for rectal application.
Okay, so fentanyl patch, is it an option here? The patient is near end of life. We will discuss more about it when we talk about fentanyl. Subcutaneous morphine is an option, but the patient is at home. So is it possible to send? Yeah.
Can we give intravenous morphine? There are some devices that have that can regulate how many ml per hour you want to give.
You can give injection morphine by IV or subcutaneous route. There is no problem. But will your hospital allow to give injection morphine to this patient to home?
Yes, that's the question.
Yeah, but we will provide injection morphine to the patient after diluting and give it to the patient caregiver, and we will teach them how to administer, not through IV route but by subcutaneous route.
So there is a question, what about buprenorphine patch?
Okay. So who asked that question?
I think Dr. Priyanka Chaurasia.
Okay. So buprenorphine is another opioid available, but the problem is that worldwide, as I told you earlier, gold standard for pain relief is morphine. And in addition, buprenorphine is available in two forms, tablets, sublingual tablets, as well as buprenorphine patch. But buprenorphine patch is very, very costly. I think two patches of 5 milligram cost about 2000 rupees. And 12 milligram of oral morphine is equivalent to 5 milligram patch. So you can see the conversion ratio. If the patient is on 30 milligram of oral morphine, and if you want to convert the patient to buprenorphine patch, then how much money are you going to waste? So buprenorphine is not usually given when morphine and other strong opioids are available. So, but if you don't have any other option, then buprenorphine can be used. But otherwise, I will not advise buprenorphine for pain relief. So here, what are the routes through which you can give morphine, administer morphine? Anybody? What are the routes through which you can administer morphine?
So, yes, sir. Myself, sir. So, from the oral, then IV, subcutaneous, epidural, intrathecal, probably those are the routes.
Yes. Any other routes? So intravenous or subcutaneous, oral?
There is oral, subcut, IV, parectal, intramuscular.
Yeah, parectal, intramuscular, epidural, intrathecal. But usually we avoid giving morphine or any other medication through intramuscular route. We usually avoid because one of the main side effect of intramuscular route is pain. So, and even absorption is very erratic. So intramuscular injection of morphine is not usually given. And this patient, he's at home, and you can see parectal morphine can be safely administered by a patient caregiver at home. So the same same immediate release morphine can be administered parectally. So you can take the tablet, add 2 drops of water, make it a paste, and rub it over the rectal mucosa. And it has the same duration of action, and the pain relief would be the same. So oral route is comparable to parectal route, and even some people say parectal route is superior to oral route. Okay, so here patient was receiving tab morphine 5 milligram 8 hourly. So you can give 5 milligram parectally every 8 hourly. Okay, now we are moving on to another patient. Mrs. K, 55-year-old lady with carcinoma of the colon, has abdominal pain, which is continuous in nature, and she is on 10 milligram morphine every 4 hourly. And she doesn't require any SOS dose of morphine. So the doctor has advised them to replace the morphine with fentanyl patch. But next day, the patient reports to you telling that she has replaced the fentanyl patch after 5 hours because there were no pain relief. What will you do now? Anybody?
Actually, you have to give time for the fentanyl to act. You have to continue fentanyl patch to act before stopping morphine abruptly. So you have to taper and stop, and then have the effect of fentanyl.
Okay, thank you. Anybody else?
Yeah, so so all sorry, so what was needed was that you would have given the fentanyl patch concurrently with the morphine, because it will take some time, maybe days, before the fentanyl reaches its maximum effect. So otherwise, the patient is currently without any analgesic. That is why the patient is having the pain.
Okay, thank you, both Dr. Gregory and Dr.
Jason.
Jason. Okay, thank you. So let's see a few points about fentanyl. So transdermal fentanyl patch. So what happens when you apply a fentanyl patch is that first it will form a subcutaneous tissue depot, and from this subcutaneous tissue depot, the fentanyl will be liberated every hourly into your bloodstream. So when you apply 25 microgram patch, that means every hourly 25 microgram of fentanyl will be liberated into the systemic circulation. But for this to occur, first it has to form a subcutaneous tissue storage. It will take about 8 to 12 hours. So when you apply fentanyl for the first time, fentanyl patch for the first time, it will take about 8 to 12 hours to act. So what you have to do is you have to continue with the previous opioid which you are giving. So in this case, the patient was receiving 10 milligram of morphine, and you have to continue it till 8 to 12 hours, even after application of transdermal fentanyl patch. But our patient replaced the fentanyl patch after 5 hours. And actually, this is something, this is a real patient story who came to us and told this story. So it is our duty to educate the patient and caregiver how much time will it take and what to do, etc. So it is very important. And as you know, the duration of action of fentanyl patch is 72 hours. And you should not shave the area because it can produce abrasions in the skin and it can increase the absorption as well. So it is not suitable for patients with unstable pain, because fentanyl, when a specific patch is applied, that much, suppose it is 25 microgram patch, 25 microgram will be liberated. We can't alter the concentration of fentanyl. So if the patient has a very severe pain which is not controlled, then you have to control the pain with the short acting opioids like morphine. You have to find out a dose which gives comfortable pain relief for the patient, and then only convert that opioid to fentanyl patch. So there are 3 types of preparations are available: injectable morphine, transdermal, and oral transmucosal fentanyl citrate. As I told earlier, injectable fentanyl is not used by many people. It is used only by some of the pain management physicians. And oral transmucosal fentanyl citrate is like a lollipop, which is useful to treat incident pain, that is pain due to movement. And fentanyl is 100 times more potent than morphine. And you can see 60 milligram of oral morphine equivalent is equivalent to 25 microgram per hour fentanyl patch. So we have a patient here, 70-year-old man with carcinoma of the lung, and is complaining of throbbing pain on right front of chest, which is continuous in nature, 5/10. He's a non-epileptic and is on phenytoin 100 milligram BD. How will you manage his pain? Anybody? Anybody?
So may I try?
Yes, please.
It's lung carcinoma. So we have to first we have to auscultate and we have to check the breathing of the patient. Then we hook him onto monitors and do a morphine trial. And I think we can directly go in for morphine, though he's on phenytoin. We have to see the creatinine clearance also before we start. I would proceed like that because he is lung cancer. And obviously, if he has come to us or with epileptic. So both of these are chronic pain.
Okay, thank you. This patient has a pain score of 5/10. So which step of the WHO analgesic ladder would we choose?
So there is a
Yes, can
response
I
on
say?
weak opioids.
Mm-hmm. It is the pain score is 5/10. So the opioids for the second step of analgesic ladder has been selected. And I
Yes,
see, yeah.
Yes, few things we have to take into consideration
Yeah.
is the fact that this patient is epileptic. So analgesics, you have to bear in mind the opioids reduces the risk that the seizure detection, for example, tramadol will be
Dr. Gregory,
relatively
your voice is breaking.
contraindicated in this.
Dr. Gregory, your voice is
Okay,
breaking. We are
maybe.
unable to understand.
Okay, I heard that word seizure. So as we have to understand that tramadol is a medication which can reduce the seizure threshold. This patient already is non-epileptic, and if we give tramadol, there is a chance to precipitate a seizure. It is better to avoid tramadol if possible, and we can start the patient on low dose morphine. That would be better. So just understand, tramadol can reduce the seizure threshold and precipitate a seizure in patients, especially who has brain metastasis or patients who are on other medications which can reduce seizure threshold. And if the dose of tramadol is more than 400 milligram, and if you give a fast IV push, all these are occasions where the patient can have a seizure. So in this patient, it is better to have low dose morphine. Okay, here is another patient, Mrs. P, on tab morphine 50 milligram 4 hourly. She attends your clinic with severe pain. You have injection pentazocine and oral morphine tablet. How will you manage this patient? We have two options: injection pentazocine or oral morphine tablet. Patient is coming to you. Yeah.
So I would like to give injection pentazocine, 1 mg per kg.
Okay. Who was that?
Prashant, Dr. Prashant.
Okay, Dr. Prashant. Thank you. Anybody else? Okay, let's see. Move on to some of the basics about opioids. So opioid, a drug to be qualified as an opioid should have two properties. One is that it should produce its action by combining with opioid receptors. So you know that mu, kappa, and delta are the opioid receptors. And another thing is that its action should be antagonized by naloxone. These are the two properties for a drug to become opioid. Okay, and opioids can be classified into three: agonist, antagonist, and agonist. So most of the opioids which we know, like tramadol, codeine, methadone, morphine, all those are agonist. Agonist means these are medications which, when combined with opioid receptors, produces physiological action, that is pain relief. So what is an antagonist? What is an antagonist?
Yes, so the antagonist is directly opposite. So the antagonist binds to it binds to the receptor, but then it does not produce any biological effects.
Yeah, antagonist acts only in presence of an agonist. So if you are not taking any opioids, and if I give antagonist, naloxone or naltrexone, it will not have any action in your body. But if you are taking morphine and I administer an antagonist, naloxone, the action of morphine will be reversed. It will be competitively inhibiting the morphine, so that you will have severe pain. So that's what antagonist will do. Agonist antagonist means on certain receptors they will act as an agonist, but on other receptors it will act as antagonist. So that's what agonist antagonist means. And you can see the difference between agonist and agonist here. Can anybody tell me what is the difference between these two group of medications by looking at this graph? You can see on x-axis it is the dose of opioid, and on the y-axis it is pain relief.
I think in agonist the dose has to be increased as the pain increases, but in the agonist the as the pain as the dose increases, the pain is come down. The other way around.
A little needs
after a certain dose there will be no relief of the pain.
Yeah, that's it. So in case of agonists, you can see the graph is going in linear fashion. That means as the dose increases, there will be corresponding pain relief. So theoretically, you should get 100% pain relief. But in case of agonist and antagonist, you can see after a certain dose, you can see till this point, when you increase the dose of agonist and antagonist, you will have corresponding pain relief. But after that, even if you increase the dose, there will not be any further pain relief. So the curve plateaus. That means agonist and antagonist group of opioids have ceiling effect for analgesia. So this group have ceiling effect for analgesia. Okay. So let's look at the pentazocine. Pentazocine, it has action, as I told you, it is an agonist antagonist. It has an agonistic action at kappa receptors, whereas it is weakly antagonistic at mu, whereas morphine is a mu agonist. Okay, and you have to understand that opioids which acts on mu receptors are the potent opioids. So if you look at fentanyl, morphine, methadone, all morphine and fentanyl are mu agonist, whereas methadone, it acts on all the receptors as agonist. So what happens here, if you give morphine, if you give pentazocine to a patient who is on high dose of morphine, what will happen? Morphine, pentazocine is going to replace morphine from the mu receptor. And the pain relief would be now mainly due to the action of pentazocine on kappa receptors, which will be very weak. So it can actually increase the pain if you give pentazocine to a patient who is on 50 milligram of morphine every 4 hours. So just understand that if a patient is on large dose of mu agonist, it is not good to give an agonist antagonist. So in this patient, I will give morphine itself, not pentazocine. So we will move on to adverse effects of opioid. Adverse effects can be divided into two, side effect and toxic effect. So what are side effects? Side effect means these are the adverse effects with therapeutic doses. So what are the side effects of opioid? Can anybody tell me?
Constipation.
Yeah, constipation, nausea, vomiting, sleepiness and tiredness, itching, dry mouth, urinary hesitancy. The first three are the usual side effects, and the last 3 are rare side effects. Okay. So constipation, it occurs almost in all patients. And as long as the patient is on any opioid, the constipation will be there. So you have to administer laxatives when you prescribe any opioid. So the choice is stimulant laxatives. So it is a laxative as well as it will stimulate the peristalsis. So example is bisacodyl, senna, or sodium picosulfate. There are many mechanisms by which opioids produces constipation. Okay. So it is very important to understand. You have to continue the laxatives as long as the patient is on opioid. And nausea and vomiting is the next side effect, which occurs in almost 33% of patients, but it is self-limiting. Maybe for the first few 3 to 5 days, the patient will have nausea and vomiting when you start opioid for the first time. And it is due to stimulation of chemoreceptor digoxin mainly. There are many drugs which acts on CTZ on D2 receptors, that is dopaminergic type 2 receptors are the main receptors which causes nausea and vomiting. And the drugs like haloperidol, metoclopramide, and domperidone are the choice to treat opioid-induced nausea and vomiting. And next is sleepiness and tiredness. It again occurs in 1/3 of the patients, but it is self-limiting. So maybe for the first week, the patient might be little drowsy, but thereafter the body will get accustomed to it, and the patient will be very active. You need not do anything for this. And next is toxic effect. We divided adverse effect into 2, side effects and toxic effects. So toxic effects means these are the adverse effects when the administered dose is higher than the required for pain relief, or when the patient's pain has poor responsiveness. How will it manifest? The patient can have delirium, myoclonus, extreme drowsiness, and pinpoint pupil. So delirium, myoclonus, drowsiness, and pinpoint pupil. And if the patient has toxic symptoms, then maybe you have to stop the medication or skip the medication for 1 or 2 doses. And when the patient become alert, you restart the opioid with a lesser dose. And probably you have to treat delirium symptomatically. And this is one of the major problem as professionals when we read about opioids. We are scared about this. So what do you think about this? Opioids causing respiratory depression. How common it is?
It is less common.
Less common. Okay, so this is a systematic review from 2003, and it is mainly talking about oral opioids. It says the patients takes their medications orally, and usually the dose is increased gradually, which ensures that respiratory depression is unusual. And if a patient has respiratory compromise, then you should seek an alternative explanation, such as does this patient has pneumonia, or does he have pulmonary embolism or cardiomyopathy, or are we administering another benzodiazepines along with morphine or any other opioids. So respiratory depression is very unusual, and you have to also understand that pain is the physiological antagonist to respiratory depression. So as long as the patient has pain, the patient will not have respiratory depression. And what about this opioids causing addiction? So there are the findings are that substance abuse as a result of medical use is low, and there is confusion between physical dependence and psychological dependence. Whereas psychological dependence is termed as addiction, whereas physical dependence will be manifested as withdrawal reactions. Okay, so what is addiction? So this is the definition from American Academy of Pain Medicine and American Society of Addiction Medicine. It says addiction is a primary chronic neurobiologic disease. So addiction is a disease with genetic predisposition. So it occurs in genetically predisposed individuals. And its manifestation and development will be influenced by psychosocial factors and environmental factors. So if you have a gene for addiction, and if you are working in an environment like operation theater where all the opioids are available, and if your friends
Sir, Shipriya, did we lose him, the connection? Yes, Shipriya, I think Dr. Sunil is not available there.
Yes,
I think
so
it's-
sir, I think we lost the connection. We will wait for
Yeah.
and some of the manifestations are patients will continue to escalate the dose of opioid without our advice, and it will be very sudden increments, and the patients know that they are using it for something else, not for the medical use, and then know that it is going to cause more harm, and they will try to get it by anyway. So and
Sunil sir.
stolen it, something like that. So these are all when you hear about this, you have to think whether this patient has any psychological dependence. So now I am moving on to a prescription. Mr. X has severe pain and you are starting him on morphine. Please write a prescription. His serum creatinine is normal. Can anybody tell me what all should be there when you write a prescription for morphine?
So name, age,
Yeah,
diagnosis,
yeah,
and the number, the case number
yeah,
or the palliative number.
yeah.
Then the morphine, the dose,
Mm,
and then we write our signature
mm,
and our seal.
mm.
Under that, we have to write a contact phone number for palliative care nurse.
Mm.
And the patient's attender, the name, the number, and the Aadhaar card number, so
Okay.
that the address and everything is included.
Okay.
Anything else?
So as per
Sorry, date.
as per the NDPS Act, you should have these things in the prescription: the patient's name, age, address, and what type of preparation are you providing, and at what strength, and how many days, and how many numbers of morphine are you providing. And you have to put your signature, name, medical council registration number, and address. So this is what you need as per NDPS Act. So in addition to this, we know that this patient is on morphine, and so we have to prescribe stimulant laxative. So usually, as I told you, stimulant laxative, bisacodyl or sodium bicosulfate can be given, and for nausea and vomiting, we can give metoclopramide for 3 to 5 days, and you can review the patient after 2 days if possible. Okay. And this is my last slide, in which I have given a comparative cost of various strong opioids available, not only strong opioids. You can see morphine 5 milligram 4-hourly. So the total dose would be 30 milligram. And this patient would need about 3 rupees 50 paisa per day. But if you want to give same pain relief with tramadol, it would need 300 milligram of tramadol, and the cost would be around 24 to 50 rupees per day. And fentanyl patch, 12.5 micrograms, which might be about 100 rupees per day, whereas methadone, the cost would be comparable to morphine. So if you are going to prescribe fentanyl patch for this patient and who is unable to afford it, he will continue to be in pain. So thank you. I will stop here.
Thank you, sir. So there's a question, should we give metoclopramide in all cases?
When you start opioid for the first time, it would be better to give a metoclopramide as a prophylactic agent, because in our culture, when somebody take morphine or any opioid and vomits 3-4 times, then they will be hesitant to take it thereafter. So better to prevent nausea and vomiting, and that's for 3 to 5 days you can give metoclopramide.
Yes, Dr. Nari, please. Ma'am, can you unmute yourself?
Yes, Dr. Nari here. I wanted to ask, if we've prescribed tablet morphine to someone, we can give that prescription for how many days before we ask them to come back for a follow-up?
Actually, when you prescribe morphine for the first time, it would be ideal to ask them to come back after 2 days, because we know that for oral morphine, it will take 5 half-lives to have the sustained blood level. So 4 into 6, 5 into 4, 20 hours. So 20 hours to 36 hours, that's what the literature says. So after 2 days, you ask the patient to come for a review, and if the patient is having good pain relief, then maybe after 2 weeks you can call them and call them for a review. And if they are from long distance, then maybe even after 1 month, and you can follow up the patient through phone call.
Okay, thank you, sir.
Sir, maybe we'll take one more question before the case presentation, because it's already 6:15. When should we add NSAIDs or adjuvant in step 3 of WHO analgesic ladder?
Okay, so NSAIDs are indicated when there is a definite indication. So what is the definite indication? It is inflammation. So if the patient has inflammation, then I would, if the patient has very severe pain and at the same time in having an inflammation, first I will give an IV morphine trial, and we'll see whether the patient's pain is responding. Likewise, in the first patient, we started him on 5 milligram morphine, and I will give him, if he has inflammation, maybe I will add ibuprofen, 400 milligram TID maximum, maybe for 5 days. And after that, I will review the need of NSAIDs, because the inflammatory pain won't be there thereafter. So I will review the situation and will provide NSAID only if needed, but I will continue with the opioid. And adjuvants also according to the need of the patient. If there is a neuropathic pain, if it is neuropathic pain, we have given a morphine trial, but we know that tricyclic antidepressants or anti-epileptic. These are used to treat neuropathic pain. So I will start a small dose of tricyclic antidepressants along with morphine, and will try to increase the dose of tricyclic antidepressants to an optimum dose. You know that tricyclic antidepressant, it will take about 2 weeks to get good pain relief. So for that 2 weeks, the opioids will give partial pain relief. And once the pain relief is taken over by the tricyclic antidepressants, then we can try to reduce the dose of opioid.
Thank you, sir. We'll take up the presentation and then we'll have the further discussion.
Okay.
Yeah, so good evening, everyone. Can I start?
Yes,
Hello,
sir.
am I audible?
Yes, please start.
Hello.
Yes.
Yeah, sure. So I'm Dr. Newstar, same year. I'm working as an anesthetist in a district maternity child hospital. So I don't have an access to case, but I'm presenting one of my wife's uncle, who I was able to be part of the care during his terminal days of his life. So he had passed a year ago, but this is the history I've taken, like during one of those times when he was doing quite well, but his pain control was not so well controlled at that point of time. So let's just go with the case. So he's an 83-year-old male. So he was diagnosed having metastatic squamous cell cancer of the cervical lymph nodes. He has ulceration of the nodes, and he is hypertensive also. Can I go to, yeah. So he's presenting a complaint. He has a swelling over the right side of the neck for over a year. He has ulceration over the swelling for about 2 months, and he has pain over the region for about 2 months. Next slide, please. So history of the illness. So he has a swelling over the right side of the neck for about a year. For the past 1 year. So during the early stage of the disease itself, he had got it evaluated, and he was diagnosed with FNSC was done, and he was diagnosed with metastatic squamous cell cancer. So the patients and the family members, they did not want any further investigations and treatment, because the treating oncologist at that point of time also gave a poor outlook of, gave a poor prognosis for any treatment outcome, and considering his age also, he may not be able to tolerate chemotherapy and radiotherapy. So from family members side, they didn't want any further investigation and treatment. So he was living with that, and the swelling was progressive in nature, and it rapidly increased in size for the past 2 months. And then ulceration also started occurring over the nodes over the past 2 months. It started increasing to present size, and pain also started occurring in the neck, in the ulcer over the past 2 months, which is throbbing in nature, and it causes him sleep disturbance. He has to wake up in the middle of the night. So there is no identifiable aggravating factor. He's relieved by taking painkillers prescribed by the physician. And NRS pain score is 8 and becomes 5 after taking those painkillers. He is eating normally and not having dysphagia. There is loss of appetite and weight loss. Bowel and bladder habits are normal. He is hypertensive for the past 10 years on medications. Next slide, please. So an examination is average build, is conscious, oriented, is having mild pallor, no jaundice, clubbing, cyanosis, orbital edema. His right cervical nodes are enlarged. And then pulse is 80, blood pressure is 150/70, is afebrile, respiratory rate 16. On local examination, is having a swelling over the right side of the neck. Is about 10 into 8 centimeters, which is hard and irregular in consistency. It is not mobile. Ulceration also is present, about 5 into 4 centimeters. Slough is present at the base and slightly blood tinged, but it's not foul smelly at present. His cardiovascular respiratory symptoms are apparently normal. Next slide, please. So treatment, he is currently on Zerodol P, aceclofenac 100 milligram, paracetamol 375 milligram twice daily, and on morphine 5 milligram for the past 2 weeks. And or he's also on amlodipine. So investigations, basically his last investigation was hemoglobin 9 grams, TLC 1000, LFT, KFT, and electrolytes were normal. Can you go to next slide, please? So psychosocial aspects. So he's a retired pensioner. He worked as a clerk in a bank. He's married and his wife is healthy. He has 3 children. His eldest son is recently divorced. His second daughter had lost her husband 5 years back to cancer. She's a tailor and has 3 school-going children. His youngest son is not married and is a carpenter by profession. So he used to like to go to church regularly. He likes to walk also. So he used to walk to his church for a distance of 10 kilometers up and down. But of late, he is not able to do that because of the pain and is also feeling weak, very weak of late. Next slide, please. So the main concern for him basically is the pain, which is disturbing his sleep and the ulceration, and also he's not able to attend a church and socialize. Next slide, please. So to summarize, he's an 83-year-old retired pensioner. He has metastatic squamous cell cancer of the cervical lymph nodes, which has ulcerated and causing a lot of pain and distress, and which has limited his socialization and decreased his quality of life. Next slide, please. So discussion points. So what are the various overall, like when we have to treat the patient, so what are the various needs that probably this patient needs to be taken care of? There are the various pain relief modalities that can be offered. So we have seen from the previous 2 sessions, I think quite a lot have been discussed, and I have also realized a lot of things in the past, the last session and today. So, and I realized a lot of other things could have been done, which probably I was not aware of at that point of time. So what's the maximum NSAID dose that can be given when we, I mean, basically, how do we use the WHO ladder in situations when we want to jump up from NSAIDs, weak opioids to strong opioids like morphine? Like the maximum NSAIDs dose before we start going to the next ladder. So what are the various strong oral opioids that are available in the Indian market? I think Sir has dealt that today in the talk. What are the various transdermal pain medications available and how effective are they? And what's the maximum safe dose of opioids that can be given? This was also this question was also there in the pre-test, which I was not aware. What are the precautions we should take or monitoring that needs to be done when prescribing opioids, and any specific instructions that needs to be given to the patient? I think we have dealt that quite a bit in today's session. And how to manage opioid overdose. Is it feasible to manage opioid overdose at home? And if patients with end-stage liver disease, or for that matter, renal disease, which we have seen today, like can we still give opioids, or how do we titrate in such patients, or do we skip it altogether? And the other aspect regarding this patient is the wound care. Maybe that might be dealt with when we deal with this case. I mean, in the later sessions, probably. Next slide, please. Yeah. So thank you.
Thank you, Dr. Minister. I think some of the questions are being answered during Dr. Sunil's session. As we are running lack of time, I'm just going to Dr. Sunil for his comments directly. And please feel free to type in your comments in the chat so that we can go ahead with the discussion simultaneously. Dr. Sunil, specifically the third question, what is the maximum NSAIDs dose that can be given before we go to the step 3? Yeah, so there are responses coming in the chat also, so simultaneously we can read that.
Yeah.
Dr. Sunil?
So in this patient, he had a metastatic ulcer on the neck. So there is a chance that this patient may have bleeding, and I think I already saw that there is blood tinge. That's what I saw in yours, one of the slides. So we have to think it in terms of the patient may bleed and can die even due to bleeding, because one of the complication in head and neck malignancy is infiltration into major blood vessels, which can lead on to sudden severe bleeding, leading on to death. So when you prescribe NSAIDs, it would be better to avoid the non-selective COX inhibitors. That is our traditional NSAIDs like ibuprofen, mefenamic acid, naproxen, etc. and if I prescribe an NSAID for this patient, if he has an inflammation, then it would be atoricoxib, which has COX-2 selectivity. So, and even I would not continue to give it indefinitely. If there is inflammation, I will give it for a few days, maybe 3 to 5 days, and we'll see whether that will help him. Or even before giving NSAIDs, I think to reduce the peritumor edema, I think it is better to give steroids here because this is an ulcerative metastatic lesion which will have peritumor edema. So maybe better to give steroids. And if in other patients, when you give NSAIDs, I think the ibuprofen, the maximum safe dose, that is 400 milligram TID would be the safer dose. And in that dose, it acts as a non-selective COX inhibitors. That is, it acts on both COX-1 and COX-2. But if you go beyond that dose, it will act more on COX-2. It will act like a COX-2 selective medication. So it will have more prothrombotic activity. So that's the maximum dose of NSAID which we usually use as per the current evidence. And another medication would be naproxen, which up to 500 milligram BD. That's the dose that we can use safely. So ibuprofen and naproxen are the two medications or two NSAIDs which can be used safely. And whatever be the NSAID, you use it for a minimum duration possible and lowest dose possible. That's what when there are more and more evidences are coming out about the side effect of NSAIDs. So it would be advisable to use minimum duration of NSAIDs with lowest dose possible. So that's what I want to say about the maximum dose of NSAIDs.
Sorry, sir, I was just typing in a response. Dr. Grigory was asking, paracetamol and morphine both has a central action. So I was just wondering, don't they act at different receptors? So do we really need to be concerned about it?
Yeah. Both accept different receptors, and as you know, paracetamol acts on a central COX inhibition. That is, they say there is something called COX-3, whereas the opioids acts on opioid receptors.
Dr. Newstar, is there any specific question regarding, like, now we have discussed a little bit, especially on monitoring while prescribing morphine? Was that part, or any opioid, was that part clear? Because you have a question in your presentation. Do we need to discuss it, or was that clear?
I think it's clear. But I think one of my questions that I've typed in the chat box is like, when we are dealing with the most common complication, adverse effects of opioids like constipation, so do we need to give bisacodyl like as long as they are taking opioids, or there is a certain point of time that there is the side effects will probably not be there anymore, we can stop bisacodyl?
Okay, so tolerance does not occur to constipation. So that means as long as the patient is on opioid, the patient will have constipation. You have to continue with laxatives, that is stimulant laxatives. And as I told you, 95% of patients will have constipation. That means 5% of patients may not have constipation, but we can't or we will not understand which is the patient who will not have constipation. So you will write a laxative, stimulant laxative for 100% of patients, and from that a few patients, 5 patients out of 100 will come to you and tell that when I take Dalcolax, I have diarrhea, I have 3-4 times motion, and then you will understand that okay, this patient is comes in that 5%, and he may not need stimulant laxative, and you will keep it as SOS dose.
So maybe one last question to discuss. The second last question, what if there is end-stage disease, deranged liver function? Can we still give opioids?
Okay. In altered liver function, we can give morphine. But if the liver function is completely altered, completely deranged, then in that situation also, we can use morphine with reduction in dose, like what we have talked about in chronic kidney diseases.
Are there any other questions that I missed from the chat? I tried to answer a few. If there are more questions which yes, Dr. Nari and Dr. Newster, we have one whole session on wound management. That's why I didn't touch upon the last question. We have a whole session. Yes, for quick answer, we do teach relatives how to do the wound dressing at home. I think that's the key behind wound dressing. Sorry, Dr. Priyanka's question, I think I missed one. OPD patient, either would you like to start with oral or IV bolus dose of morphine?
If the patient is in severe pain, we always do a IV morphine trial and then we'll convert it into oral morphine. But if you don't have injectable morphine, then start with the oral morphine. And I would also like to mention a few points regarding what to monitor when the patient is on morphine. So we already talked about that, but you have to ask for the pain relief. Then you ask for toxic symptoms like do you have delirium, myoclonus, extreme drowsiness, and you also advise the patients to keep the morphine out of children and keep it in a safe place, and don't give this medication for anybody else, because we know that many patients when they take some analgesics and they will give it to the neighbors also if they have pain. So that has happened. Ask them not to give. This is some medication which has to be which is controlled, which is a controlled substance. So don't give to anybody. This is only for your use. And you give a number, phone number, in case if they have any doubts.
Thank you, sir. If there are more questions which we have not touched upon, just send a message in the WhatsApp group, so we'll come back. We'll try to write back to you or text you back. Thank you so much, everyone. And thank you so much, Dr. Newstar, for the presentation, because it had a lot of questions to discuss. And it had, kind of we covered that in the session, but it was good to see those questions, because we know that these are the questions that people really want to get answers for. Thank you so much, Dr. Sunil, for the wonderful session as always, and for your time in the evening. Shri Priya.
Thank you, Sunil sir, for joining us and for that elaborative session. And we hope that since this has been a very descriptive session, there might be some more queries, as Dr. Sridevi said. Please do feel free to get in touch with us either through WhatsApp or SMS or through mobile. We'll be very happy to answer your queries. So with that note, this is Shri Priya along with Dr. Sunil Kumar and Dr. Sridevi signing off from the Tips Eco Hub. See you in the next session with another interesting topic. Till then, everyone, stay safe, be happy. Bye-bye.